Göran, reflecting on your experiences in leading change in quality improvement and safety, what advice would you have for our leaders at Singhealth?
I think it's very important to find the leaders that think this is fun and see the connection between what benefits the patients and the work. And very often quality improvement initiatives starts from the top, but you have to build a culture where you both have leaders at the top that ask for this, but people that are doing the daily work and likes to work with the work to start to do improvement initiatives.
In terms of the culture, you talked about building this culture. What are the top few things that you think we could help to create this culture at all levels?
My experience from Singapore is that you have very ambitious people and they are doing a fantastic work. But there are two things I have reflected on, and one is that you are still lacking measures for the daily work within the system. So I think it's important to have dashboards and help people to see the performance of their daily work. And the second thing is to recognize the people who are doing the good job. So you have leaders on the floor that support people and not just ask for more and more production.
What were some of the ways that we could recognize these people?
I think to take the time every day in front of the measures or in any place to just have a discussion. What have we done today that we can do better tomorrow?
Okay, thank you.
Thank you.
We're in Paris at the International Forum on Quality and Safety in Healthcare. My name is Camilla Wong. I'm the Deputy Director of the Allied Health Division at Singapore General Hospital. With me, and representing Singhealth, I have my colleagues, Professor Lim Soo Hia, Senior Director of Nursing at Singhealth, and Dr. Manuel Gomez, Head of Newborn ICU at the KK Hospital for Women and Children. Our theme today is Leadership for Transformational Change in Healthcare Quality and Safety. We are honored to be joined today by two leading experts in quality improvement and safety in healthcare, and it's my pleasure to introduce them. Dr. Berwick is the former president and founder of IHI, Institute for Healthcare Improvement, and former administrator of Centers for Medicare and Medicaid Services. Dr. Federico, who is an executive director and strategic partner with the Institute for Healthcare. Singhealth is the largest healthcare group in Singapore, offering a complete range of multidisciplinary and integrated medical care through our network of 2 hospitals, 5 national specialty centers, and 9 polyclinics. At Singhealth, we're engaged in patient safety, activities such as prevention of medication errors, and prevention of healthcare-acquired infections and needle stick injuries that are top-driven. There are pockets of excellence in some of the institutions and departments in areas such as international benchmarking and perinatal care. I'm going to jump right into it and start the ball rolling. I would like to direct this question to Don, perhaps. Yeah. Reflecting on your experiences of leading change in quality improvement and safety, what advice would you have for our leaders at Singhealth?
Thanks for having me, Camilla.
Thank you.
Thank you to Singhealth. Well, one useful framework that the Institute for Healthcare Improvement, IHI, uses is that the roles of leadership include at least 3 essential elements. We call it will, ideas, and execution. And that always serves me well. Will means building will. It means a leader who's absolutely clear about the need for improvement, is unapologetic about it, directed, can explain why, and shows by their personal behavior that improvement, constant improvement, is crucial, and sets aims. Ideas means a leader who arranges for openness, a sense that somewhere in the world there may be someone who knows how to do this or know better than we do. Let's find it and bring it in. Constantly able to supply new ideas, because if you keep doing the same thing you're doing, you're going to get the same results. And execution may be the hardest. It means linking the pursuit of improvement to the day-to-day activities of leadership. It becomes incorporated in the day-to-day deeds to look at performance, to help support the search for ideas, to celebrate the inventiveness of the staff, to find new ways to do things. A whole set of personal behaviors that everyone's watching, and that execution piece is crucial.
Yeah. What are some of the perhaps specific suggestions that you might have to do this last bit? Which actually for us at Singhealth, I think that's the most challenging of
execution.
all. Yeah. Yes.
Be there. I think that maybe the thing that's most important, in my view, is the leader who's out of her office or out of his office, who goes where the work is. In Japanese say, go to the gemba, go to the shop floor, and engage. There people want to see you, and you will learn, and that's crucial. And be persistent in the most positive way about the goals. If your goal is safety, and that's an important one, look for it, inquire, always be open. Another form of that is to, I guess you'd say in other industries, get the customer in the room. That is really important in the case of healthcare, to have patients and families present, speaking up, enabled, powerful in the system, so you're listening and showing with your behavior that you're in touch with them.
Thank you.
We also, at the Institute for Healthcare Improvement, have a white paper, 7 leverage points for leaders, which I think is critical to help with that execution piece, understanding what should I be doing, what should I be asking for, what are the key elements around measurement, the patient engagement piece. Yes. It's a good guide for leaders to be thinking, what's my role? The other piece that's really important is making the time. That is, Dawn said, go to the front line. Most leaders will tell you, we're too busy, we don't have the time. And we have some examples of organizations that have shown their commitment where leaders have carved out time. They call it white space. Cannot be overscheduled. That's the time that I go to visit the wards to see what's going on. That's a critical aspect.
Okay, thank you. Yeah.
Maybe I'll direct this question to Frank, and I welcome views from Dawn. How should leaders manage this change effectively? In particular, how can we better engage our clinicians? I believe this may be a universal problem, but I welcome your thoughts on this.
I agree. It is a universal problem because it's not just doctors, but it's nurses, pharmacists, and everybody else that needs to understand what is it that we're actually doing? What are we trying to improve? The first thing is, do you know how well you're doing now? Has anybody looked at our performance today? Because most of the time people don't have a good idea of how are we performing? Are we actually achieving the results that we want to achieve? Are we delivering the care that we want to achieve? And we find, especially with doctors, data speaks volume. That's an important piece. The second is that as you approach quality improvement, as you approach some of these processes, many will feel, well, you're trying to standardize everything and it's cookbook medicine and my patients are different. And it's working together to understand that there are things you can standardize and you should. And then there are other things that are patient-specific that you may have to vary from that standard protocol. But unless you standardize to a point, you have so much variation you don't know what to work on. And what we found is by taking that approach and giving them the opportunity to constantly view their performance and respond and change appropriately, that has been very effective. Another colleague of ours talks about trying to engage a doctor in a small test of change. And most will resist. And he said the approach is, Don, would you try just one time with me? And that one-time engagement then opens the door to say, you're right, I think we might be able to do this even better, and get their input in changing the processes and what needs to be done.
I agree with absolutely all of that. Some other ideas, some people have been exploring what's known as a physician or organizational compact. That means being explicit about what the agreements are about what an organization offers the clinical staff, what the clinical staff offer the organization, in the form really of a worked-through specification of that understanding. That process can be very helpful, and the process is more important than the product, just a conversation about that. The other thing I'd advise is I've always seen among clinical staff, physicians, nurses, pharmacists, there'll always be sort of three groups. One will be champions. They're ready to do this. They're ready to be involved in interdependency and goal setting and in really learning improvement skills. Those are to be celebrated, and helping these people become visible models and really, visibly congratulating them and giving them latitude. The second group will be most doctors and nurses and other clinicians, and they need learning. You've got to have the time. You need to actually support their journey of learning about the science of improvement and sciences of safety and better teamwork. And the third will be people who will be resistant. And my own advice is leave them be, unless they're in an important, influential managerial role, in which case they may need to be somewhere else. But I always go for the champions and really make them the heroes.
Unfortunately, we don't have many in the first category.
You may have more than you know. I've often talked to groups of doctors, and you see there's a sparkle in the eye. There's some you can sometimes the person who seems the most resistant at the first, they're just inquiring. You'll find them there. They will be there, and it may take some doing.
And you also have to have a little bit of success. When one of our colleagues at a Boston hospital was teaching teamwork and communication training, he went to the willing. The ones that Dawn mentioned are the willing participants, the few up front. And as they were improving their processes, the word started spreading. Mm-hmm. And the other ones said, well, why didn't you ask me? I would be part of that. And slowly but surely, yes, and you do wind up with the few at the very end who aren't necessarily interested, don't want to be part of it. That's a different problem. Let the peer pressure work with them, and they'll be part of it eventually.
For a leader who's interested in doing this more with some data, there's some wonderful surveys you can do that are well established now, culture surveys, where the staff can speak about what they're seeing in the environment and what the actual operating values are. And a lot of leaders can get pretty surprised about. They think the culture is one way, but they learn it's quite different. And I think those data can really help people get their focus.
Thank you.
The general opinion of the staff is that patient safety and quality lies in the roles and responsibilities of leaders, which they refer to as senior management, HODs. Now, how do we want to get our staff of various levels to get engaged, to motivate them to take on the leadership role in patient safety and quality?
Well, first off is helping them understand what it is you're trying to achieve. Again, do you know how we're performing today? That's very important. Secondly is being a leader sometimes is frightening. What does that mean? I have to step out, I'm taking a risk, so you have to manage that as well. And I think at each layer of the organization, it's important to know what skills do they need to be involved in quality improvement, to be a leader in quality improvement. So we have colleagues who have worked with us, strategic partners like Kaiser Permanente, country of Scotland, Cincinnati Children's, that have looked throughout the organization and developed the capability for people to lead quality improvement efforts. You can't just expect someone to step up if they've never done it, if they don't know what the tools are. So they've taken a very structured approach in identifying key people, giving them the tools, giving them the time, and letting them become the leaders and continuing with the efforts. A major group that we tend to overlook in all of this is the middle managers, because the middle managers translate what the leaders want to what the frontline staff should be doing. And unless we address that, and unless we help the middle managers know their role and change the expectations, as Don said, just as you have it maybe with a physician, you need to have that with the middle managers. We expect that your ward, your work area, will be one of the safest, and you'll have efforts. We'll give you tools, and then if they are doing their job, then the frontline people will feel more confident. And we have, again, many examples where middle managers have become confident and able to lead quality improvement programs where their frontline staff now become champions. And you step out of the way because they're going to run you over if you don't.
Yes, and to that I'd add a kind of leadership by example. So if you expect hand washing to be uniform in the hospital, the first person who needs to wash their hands as the chief executive. If you want people to learn about improvement skills and how to understand healthcare as a process, the first people that really have to learn that are the board of trustees and the executive team. You can't skip that. The staff will not do what you say they should do. They'll watch what you do. And so the investment of senior leaders' time to actually learn and model what they're after authentically is crucial. The middle management issue is very, very important one. I want to emphasize what Frank said about that. That is really where a lot of traction gets lost. And I think some serious investment in helping middle management, and what's essentially, it's a change in their self-concept from decision maker, controller, standardizer to coach, support, encourager. That's something you have to really help them with.
Earlier, Camilla introduced Singhealth. We have 2 big hospitals with all the institutions. Now, every institutions are doing their quality, patient safety. Even within the hospital itself or the institution itself, we have various groups of staff. Now, how do we bring them all together to share the patient safety journey and all those areas? The other questions I like to learn from, the expert like yourself is how do, when we talk about patient safety and quality, it's all related to patient. But do we hear from the patient? How do we get them to come in to be part of the team?
So, Don, I'll take the first part.
Yeah.
We are working with one hospital in the United States where they have 5 intensive care units. There are actually 2 buildings with 5 units. And they're all working on improving the care that they deliver in the intensive care unit. And yet, each one was doing the work without learning from the other.
Yes.
And what we did is just brought them together in one room and had them share. And what we saw immediately was someone said, I have a problem. Can anybody help me? And somebody else said, we've done that. And another person said, I've got this great new form I developed. Does anybody want to test it? It has to be structured. Because even though within the same hospitals, you may find that they may connect with some other ICU elsewhere before they connect within the 2 hospitals. So you do have to have a structured process. It doesn't have to be long meetings. It could be just an hour gathering once a month, depending on how fast the work is moving, and getting them to share the information. What's really important, though, is do you have run charts? Do you have the data available that people can see? Because that gets people excited. That gets people to say, well, how come you're doing better than me? Let me come and learn from you. And I'm doing better. Let me share with others what I'm doing. So it takes a little structure, but it's really important to do. And much as at IHI, when we have our collaboratives, we bring number of hospitals together. You could be having your own mini collaborative within your own 2 hospitals to get that going.
Yeah, Frank's using the word collaborative, and I want to emphasize that also. So IHI years ago developed breakthrough series collaboratives, which were wonderful. They still are, where many hospitals working on the same thing come together, sending teams, exchanging, going home, trying things, getting back together. We used to say, all teach, all learn. So everybody's part of that. You can do that within an organization as well, and I think it takes time, it takes investment, but an executive who encourages that says, well, take the time, get together, learn what each other are doing, visit each other. That's very important. In some ways, your second question seems to be also the answer to the first, because the patient, the family,
Yes.
they don't tolerate this fragmentation. Now, once they're in the room, they're saying, wait a minute, you mean you don't talk to each other? And so I think it's a very important idea is to get patients and families into everything that's going on. Governance, design teams, improvement work, not just advisory committees, but those are important too, but everywhere get a new role for patients and families to help create the pathway. They'll insist on interactions and really support that idea that we're all in this together.
Do we bring the family members or patients to be part of the members in the committee, or how do we engage them?
Completely, not in a token way. And yes, I think patients and families should be on boards of trustees. If you have a committee in your hospital that's working on safety, there should be patients and families, not just speaking to the committee, but actually in the process. I think it should be a habit to ask patients and families, how are we doing? What do you think? One of the great innovations, maybe Frank knows more about this than I do, is multidisciplinary rounds, where when you're rounding on the patients, first of all the disciplines are doing it together. It's not the doctors rounding and the nurses rounding and pharmacy, but they're all together. And the best models, the patient is in the rounds. They're actually, and the family member, they are the team. And it's initially, nurses and others object. They may say, well, it doesn't sound right, or will be inconvenient, or will slow us down. No, it'll help. You've done a lot with the multidisciplinary work.
And it helps because then the patient knows what the goals are. Patient knows what the expectation. Family knows what to expect. And you can plan better for discharge, plan better for the care, the follow-up care that's necessary. So that's key. And as you continue to think about patient engagement, I know one hospital where the new chief operating officer was interviewed by patients.
Oh.
So before the decision was made, those patients were on that committee that helped interview and decide who should be hired. Key element to getting it done. Now, who do you pick for patients?
Yes.
Good question, because that is something that needs to be dealt with. Our recommendation, and from our experts who work with patients, is someone who's passionate about the work, someone who really has an opinion to offer, not someone who's there that has something against the hospital that they want to, because then they have a personal agenda. But respect that person as a member of the group. When you start talking in the group, make it a rule, we can't use medical language, because we want to make the patient included as part of it. And you start talking in medical language, the patient gets excluded. And listen, because sometimes we design things thinking that the patients want that care. I mean, they want good care, but we'll do extra things, and the patient said, that's not important to me. What's really important to me is that I get my medications with my instructions at a time that I can really pay attention to you, and then be able to go home and take them.
One idea, if I could just add one other thought, many of your staff have been patients. So the tradition, I think, in medicine and nursing and training is, well, you keep that stuff separate from your professional role. I don't think so. I think that I've seen hospitals who have engaged staff members who have had an experience of care and say, we need to know everything you saw, everything that happened. Bring it to us. It's a gift, and we can work with that. And so allowing that kind of connection to one's personal experience among the staff, that can help.
In quality, in patient safety, we collect data, and we have dashboards. Sometimes there are too many data that we're collecting, and the staff felt that this is really fatigue collection. So how do we prioritize, and how do we target which data should we start collecting, and which one should we start acting on?
So I'm glad you said that. So there are data that you have to collect, yes, because of requirements, whether it be government or accreditation agency, that you have to do. In speaking to a colleague yesterday, we were talking about her own quality improvement efforts, and I said, if you go to one of your wards, can you ask the manager of that ward, how are you performing on hand hygiene? Or how are you performing with central line infections? Can you tell me what your rate is? And she said, when the quality department gives us the data, we know. And I said, that means they don't know, because by the time they get it from the quality department, a lot of time has gone by. That's not to put down the quality department. They have a job to do. But if you, in real time, cannot tell how we're performing, how can you fix the problem? Because if it comes to you a month later, 2 months later, how will you remember why it didn't work when you had the failure? So it's very important to, one, collect what you have to collect. That has to be done. And then, based on where you think you're working, can we collect how we're doing with our infection rates? Can we collect what we're doing in the ICU with our central lines that we may have for our babies, or in medication issues that we may have? And then focus on those. And once you start displaying that data, put up the run charts. What we've seen in successful organizations is they will post their results for everybody to see, including patients. And there's a fear. We don't want patients to see that. And yet, every place that has done that, patients ask, and they're proud that the organization is doing something to make it better.
I think Frank and I have both seen what you talked about, which is organizations that produce massive amounts of data. They come in big, thick books and big tables, and it can be very wasteful. But understanding what's important and being able to focus in on the most important things to watch is crucial. In IHI, we talked about whole system metrics. This is for governance and senior executives. A pretty small number of very significant points you're going to watch to mark overall organizational performance. At the front line, what Frank said is crucial, which is it's real-time data that you're enabling the front line to collect and use. One of the things that I think senior leaders underestimate is data interpretation. And Frank, for example, is referring to run charts. Well, that's a particular way to show data. We're not taught that in medical school, and I don't think it's taught in management programs, but it's one of the skills in quality management is to understand how to display data. I would urge Singhealth and others to invest in education and learning about data interpretation. And there's tremendously powerful tools for that, but you have to really learn them.
And talking about dashboards that the leadership sees, usually they're tabular, and it's visually difficult to understand what does it tell me, whereas a visual graph is much more powerful.
Technically, the root science of modern improvement is statistics, and people kind of forget that. And so understanding what in industry is called statistical process control or simple tools for measurement, very important. Learn it and master it.
Well, our time is almost up. But before we go, I have just one last question for the both of you. What would be your key message for us at Singhealth? I know we talked about a lot of things, but what are your key messages?
Pretty basic. Intend to improve would be my key message, which is, the biggest enemy of improvement is self-satisfaction. And it takes courage to turn the lights on, to say, we're not where we want to be, and to name the goal, without blame, without recrimination, to name the goal and say, we are going to do this better every single day. If you don't intend to improve, you won't.
And to support that, the leaders, the middle managers, the frontline staff, the clinicians need to know how to improve. They need an improvement methodology. There are many out there. Not all are good for everything. We use the model for improvement as our foundational work. But the frontline staff need something that helps them say, if we have a problem, the leadership needs to know, we do have a problem. How do I encourage my staff to pick the tool and then go ahead and do it?
Well, thank you so much for taking the time to have this session
and
with us.
Congratulations on your great work. You're already doing good work.
Thank you very much.
Thank you very much.
And thank you all for joining us.